Oh,
Hey guys, I'm Autumn.
I'm Trina.
We are going to do our Build a Brain on cocaine. We're going to go over and explore how cocaine affects the brain across the three states, meaning sober, intoxicated, and withdrawal. We're going to focus on neurobiology of addiction, including the changes in dopamine pathways, brain regions involved in the reward and decision making, and how these changes contribute to dependence and relapse risk.
Okay, so let's talk about cocaine routes of administration and forms, primary forms of cocaine, and how route of administration influence its effects on the brain. Cocaine is a central nervous system stimulant that increases dopamine by blocking reuptake transporters, but the speed at which it reaches the brain varies by route. Intranasal use produces a slower onset, while smoking and intravenous injection deliver cocaine to the brain within seconds, resulting in rapid and intense dopamine surge. These faster routes create a stronger reinforcement signal in the nucleus accumbens, significantly increasing addiction risk. Although tolerance develops to the euphoric effects, it does not develop to cardiovascular toxicity, which contributes to overdose risk. Detection times are relatively short, but repeated use leads to neuroadaptations, including reduced dopamine receptor availability and increased dependence.
Scary stuff. So this is our mechanism of action. Cocaine blocks the reuptake transporters of dopamine, neuroepinephrine, and serotonin. This synapse diagram shown here with the red X marks on dopamine, serotonin, and neuroepinephrine transporter. Normally, meaning in a sober brain, dopamine gets recycled back through the transporter. Cocaine blocks it, and dopamine floods the nucleus accumbens, producing intense euphoria and resulting in that addiction. And over time, the brain adapts by reducing receptor numbers, building tolerance and dependence.
Okay. Key brain regions. Cocaine affects five key brain regions within the dopamine system. The ventral tegmental area, or the VTA, releases dopamine into the mesolimbic, I can't say it still,
You said it. That was perfect.
and mesocortical pathways. The nucleus accumbens is the primary reward center where cocaine causes dopamine to surge several times above baseline. Over time, the striatum becomes involved in habit formation, reinforcing compulsive use. The prefrontal cortex, responsible for decision making and impulse control, becomes progressively impaired. The
Amygdala.
amygdala drives stress and cue triggered cravings, while the hippocampus encodes drug associated memories that can trigger relapse. The diagram illustrates both the mesolimbic pathway to the nucleus accumbens and the mesocortical pathway to the prefrontal cortex, showing how reward, behavior, and control systems become interconnected and dysregulated.
All right. My favorite brain, the sober brain. This slide is representative of that baseline sober brain in normal neurobiological functioning. Dopamine is released in controlled amounts and rapidly recycled through that reuptake transporters, maintaining the balance in your reward system. Other neurotransmitters, including serotonin and norepinephrine, remain at stable levels, which supports good mood, attention, and stress regulation. The prefrontal cortex is fully active. This is an adult brain, by the way, allowing for that effective impulse control and decision making, goal directed behavior. And so there's a lot more consequential thinking happening within that prefrontal cortex sober brain. This brain image reflects the balance, showing regulated metabolic activity across both cortical and subcortical regions. This stable, well regulated system is what becomes disrupted with the cocaine use.
Okay, intoxicated brain. Chronic cocaine use disrupts brain function over time. particularly within the dopamine system. Cocaine blocks dopamine reuptake, causing repeated surges of dopamine in the nucleus accumbens, often several times above baseline. In early stages, around 1 month of use, the brain begins to adapt by downregulating D2 receptors in the striatum and nucleus accumbens, and early impairment in the prefrontal cortex functioning emerges. As use continues beyond 2 months, these neuroadaptations become more pronounced, with significant reductions in dopamine receptor availability and decreased activity in the reward circuitry. At the same time, dysfunction in the prefrontal cortex worsens, impairing judgment, impulse control, and decision making. These changes reflect the brain shifting from voluntary use toward compulsive patterns, driven by reduced sensitivity to natural rewards and increasing reliance on the drug to achieve dopamine activation. Norepinephrine spikes driving elevated heart rate and blood pressure. A range of physical symptoms driven by elevated dopamine and norepinephrine activity. These include increased heart rate and blood pressure, rapid breathing, dilated pupils, and decreased appetite, and heightened energy or physical agitation. Many also exhibit restlessness, increased body temperature, sweating, and reduced need for sleep. As stimulants effect intensify, symptoms can escalate to tremors, muscle tension, and in higher doses, risk of cardiac strain, arrhythmias, or seizure activity due to overstimulation of the central nervous system. Effects are dose dependent, escalated to potentially fatal cardiac events.
Bummer news, dude. State 3, the withdrawal brain. I also want to note here that this is in acute withdrawal. During acute withdrawal, the brain is experiencing significant dopamine crash. The level is falling well below their baseline due to the use of, and so therefore the overstimulation. Chronic cocaine use leads to that downregulation of the D2 receptors in the striatum and nucleus accumbens, resulting in the blunted reward system, like Trina was just talking about. And then that can lead to severe anhedonia, which is that like inability to experience joy or look forward to looking forward to activities that you used to enjoy, not being able to achieve feelings of happiness and pleasure because of that overstimulation. At the same time, the stress systems become highly active, particularly through increased corticotropin releasing factor activity, contributing to anxiety, irritability, and dysphoria. The prefrontal cortex remains impaired, reducing the impulse control and emotional regulation, which can also be part of that relapse risk being pretty elevated still during this time. This combination of low reward signaling and heightened stress response creates that powerful drive to use again. And individuals often experience significant physical symptoms driven by a sharp drop in the dopamine and increased stress system activity, including that extreme fatigue, disrupted sleep patterns. They can be experiencing hypersomnia and insomnia, increased appetite, headaches, sweating and chills, and a general sense of physical discomfort. Many also report slowed movement, experiencing poor coordination, feeling heavy and sluggish in their body, and alongside periods of restlessness and agitation. Even though they are really tired, they can become pretty seemingly energetic due to that agitation. These symptoms reflect the brain's impaired ability to regulate basic physiological functions during this acute withdrawal phase.
Okay, so the withdrawal brain. The brain shows partial recovery but remains significantly dysregulated. Dopamine D2 receptors begin to increase, but levels are still below baseline, resulting in continued blunted reward system and reduced sensitivity to natural reinforcement. The prefrontal cortex and anterior cingulate cortex remain underactive, contributing to ongoing difficulties with impulse control, decision making, and emotional regulation. While the the amygdala remains overactive, maintaining a heightened stress response. Structural changes, including reduced gray matter volume and weakened white matter connectivity, continues to impact communication between brain regions. Physically, individuals may experience low energy, persistent fatigue, sleep disturbances, headaches, and ongoing appetite changes, along with periods of restlessness or tension. Although some mood and cognitive improvements occur over time, the brain still is in a vulnerable state, and relapse risk remains elevated due to lingering neurobiological and physiological dysregulation.
Mhm. All right, here we're going to do this side-by-side comparison of the three states. We have from left to right the sober brain, moving into intoxicated and weaning into early withdrawal, and then post-acute withdrawal, which, to clarify, is 2 to 4 months after last use in that post-acute withdrawal in this image. We compare the brain here to the dopamine is released in the sober state. The dopamine is released and regulated normally, as we've discussed, supporting that stable mood, decision making, consequential thinking, and reward from everyday activities like food, sleep, exercise, sex, positive conversations, etc. During intoxication, cocaine blocks the dopamine reuptake and causes that rapid surge, followed by a crash. And then that disrupts the reward system and impairs the prefrontal cortex functioning. Over time, that's leading to the reduced D2 receptors that we've talked about, that availability. And in the post acute withdrawal stage, some of the recovery begins, but the dopamine activity still remains below the baseline, and the reward system is still blunted, and the prefrontal cortex is still impaired. This ongoing dysregulation contributes to, as we've discussed, some of these behaviors and observable, like facial expressions, depression, anhedonia, and the increased relapse risk. You can see the change in activity in the brain scan images where we have higher activity in the sober brain. And then you can see as that slowly diminishes over these different states there.
Okay, so these are cognitive and behavioral impacts. A sober brain, it is, I mean, normal. Intoxicated, your short-term memory is impaired, strong cue memories forming, withdrawal, so sorry, it executive function, sober effective, intoxicated, significantly impaired. Withdrawal, you stay impaired. Tolerance critically develops to euphoria, but not cardiovascular effects. So I think it means like it can affect your heart no matter what. Like, so you think you're not getting as high, and so you keep doing more and more, but the effects are still affecting your heart and all of your cardiovascular symptoms, especially if you have underlying um sometimes people don't even know heart or cardiovascular issues, then cocaine will definitely increase your chances of having heart attacks and strokes.
Yeah, super scary. All right. The tolerance to cocaine is selective, develops to euphoria, but like Trina was saying, it does not develop to the cardiovascular effects. So as you're increasing that dose and chasing the high, your heart and blood vessels face escalating danger with no warning. Like you're not able to interpret that, and so these physiological effects are going to happen without you recognizing that they're happening. The graph on the right shows cocaine deaths in England and Wales rising dramatically from 2012 to 2017. And this does reflect a global pattern. Tissue dependence develops because the brain physically reduces receptors numbers adapting to constant stimulation. Um, yeah, so this can kind of create that overdose that can potentially become fatal because of the cardiovascular system being overstimulated.
So the thing is cocaine use disorder rarely occurs alone. It's most prevalent driven by shared dopamine dysfunction. ADHD is notable because cocaine temporarily improves focus. Well, any stimulant generally helps improve focus when someone has ADHD, um, creating very high reinforcement. PTSD is especially common in women where trauma drives stimulant use as coping. The infograph on the right shows the bidirectional relationship. Mental health conditions drive substance use, and substance use worsens mental health, creating a cycle that must be broken. So like in our internships, there's often a lot of clients that have co-occurring disorders with a mental health diagnosis as well as a SUD.
Yeah. So just keeping in mind that people um, are generally using as a coping skill is what we're saying. And so being mindful of some of these mental health conditions that they may be experiencing while they're also trying to recover and maintain sobriety. So treatment approaches for cocaine use disorder, there's no FDA approved medication specifically for cocaine use. So psychological treatment is primary. Psychosocial treatment is the primary approach. Bupropion is used off label for the co-occurring depression. Iron actually has been found to address some of those physical discomforts, such as restless leg syndrome in with the withdrawal period. Benzos manage the acute overdose. So, meaning like if you had some cardiovascular effects from it. Contingency management, which is shown in the infographic on the right, has the strongest evidence base for stimulant disorders, improving treatment outcomes by 50% of longer abstinent periods and increasing program participation by 38%. Cognitive behavioral therapy helps identify triggers and build coping skills. Primary relapse triggers are drug cues. So those memories, and those are going to be the strongest predictors for those relapse. That's going to be things like not being able to change your habits and your routines or your environments. And so that's why this like CBT is best practice for stimulant use recovery.
Okay, so chronic cocaine use produces lasting structural and functional brain changes. The PET scan shows that months into abstinence, the brain has began recovering. This is evidence of neuroplasticity and recovery. Dopamine function and receptor sensitivity gradually improve during sustained abstinence. However, heightened sensitivity to drug use may persist for years, which is why relapse prevention is lifelong. Relapse is not a moral failure. It does reflect ongoing neurological changes in a brain that is still healing. So, I mean, after stopping cocaine use, it takes a long time for your brain to heal and for you to like get back to what like your normal state is. And you often can feel triggered if you don't work a program for the rest of your life in certain situations.
That's true. Cool.
And these are our references. Thanks, guys.
Thanks.